When cellular glucose metabolism fails, the body pivots to an alternative fuel source to survive. But when the logistical network responsible for transporting that fuel breaks down, the result is the leading cause of global mortality, cardiovascular disease. Diabetic ketoacidosis and atherosclerosis both arise from mechanical failures within the body's unified lipid distribution network. The liver is the body's metabolic distribution hub, directing lipid traffic down 3 biochemical pathways: alternate energy production, structural molecule synthesis, and a systemic transport network. Energy overload drives ketoacidosis. The structural path is targeted by statins, and transport failures cause coronary artery disease. This system ensures that lipids function as reactive, essential cargo rather than a pathological liability, necessitating a precision logistics network to safely navigate the water-based environment of the body. The first pathway governs energy. When a cell lacks intracellular glucose, it is forced to oxidize fatty acids at an extremely high volume to meet its ATP demands. This metabolic map illustrates how the breakdown of adipose triglycerides floods the liver with fatty acids. This creates a molecular bottleneck where the liver produces acetyl-CoA faster than its TCA cycle can process it. To clear this accumulation, the liver diverts the excess acetyl-CoA into ketone bodies. This specific diversion frees up coenzyme A, allowing beta oxidation to continue unhindered. Following reaction steps 1 through 3 in this diagram, we see acetyl-CoA converted into the primary ketone bodies, acetoacetate and beta-hydroxybutyrate. In step 4, acetoacetate undergoes spontaneous decarboxylation into acetone. This volatile compound creates the characteristic fruity breath odor observed in diabetic patients. These ketone bodies are exported to peripheral tissues. The brain, which cannot metabolize fatty acids directly, absorbs these ketones and oxidizes them back into acetyl-CoA for fuel. In type 1 diabetes, an absolute lack of insulin eliminates the metabolic brakes on this process. The liver is flooded with fatty acids, leading to unregulated ketone production. Because these molecules are acidic, they overwhelm the blood's buffering capacity, resulting in diabetic ketoacidosis. What evolved as a survival mechanism during starvation becomes, in a diabetic state, a source of systemic acidosis. Acetyl-CoA also serves as the fundamental building block for structural synthesis, driving our second pathway. Cholesterol is a biological necessity. It maintains cell membrane fluidity and acts as the required precursor for steroid hormones and bile acids. While obtained through diet, the liver also runs its own synthesis, converting acetyl-CoA to HMG-CoA, which is reduced to mevalonate and assembled into cholesterol. The critical bottleneck is here. HMG-CoA's conversion to mevalonate is catalyzed by HMG-CoA reductase. This rate-limiting step dictates total cholesterol production. By identifying this enzymatic constraint, medicine developed statins to treat elevated LDL cholesterol. Statins competitively inhibit HMG-CoA reductase, halting internal production. To compensate, the liver upregulates surface receptors to pull LDL particles directly out of the blood. This demonstrates how targeting a single enzymatic step can effectively recalibrate a patient's entire systemic lipid balance. Regardless of their origin, lipids face a logistical problem. Cholesterol and triglycerides are hydrophobic and cannot travel freely in the water-based bloodstream. The solution is to package them inside specialized protein-coated vessels known as lipoproteins. The intestine packages dietary fat into chylomicrons, while the liver packages synthesized fats into very low-density lipoproteins, or VLDL. As VLDL particles circulate and drop off triglycerides to tissues, they shrink, increasing in density, and transform into low-density lipoproteins, or LDL. LDL serves as the primary carrier delivering cholesterol to peripheral tissues. However, when levels are excessive, these particles accumulate in the plasma, leading to its common label as bad cholesterol. To maintain balance, the liver also secretes high-density lipoprotein, or HDL. As seen here, mature HDL facilitates reverse cholesterol transport, scavenging excess cholesterol from tissues and returning it to the liver. Because it prevents peripheral accumulation and possesses antioxidant properties, HDL is clinically characterized as good cholesterol. Cardiovascular health depends on the homeostatic balance between outward LDL delivery and inward HDL clearance. Dyslipidemia occurs when this balance breaks down, characterized by high LDL and insufficient HDL clearance. Excess LDL particles circulate with nowhere to go, eventually penetrating the endothelial lining of the arterial wall and becoming trapped in the subendothelial space. Once trapped, these LDL particles become oxidized, transforming into highly reactive atherogenic molecules. This triggers an immune response. Macrophages infiltrate the arterial wall and consume the oxidized LDL until they are engorged, transforming into lipid-laden foam cells. The accumulation of these foam cells creates an atherosclerotic plaque that physically narrows the artery. A heart attack is often the catastrophic endpoint of this decades-long biochemical failure, occurring at the microscopic level. These three pathways form a single integrated system. The body's global nutritional state determines which pathway the liver prioritizes. In a starved state, the system shifts left, maximizing the ketone pathway for survival energy, but risking the development of ketoacidosis. In a state of caloric overload, the system shifts right, maximizing cholesterol synthesis and lipoprotein transport, which can drive systemic lipid accumulation and plaque expansion. Managing these clinical outcomes requires an understanding of these specific enzymatic choke points. Lipid metabolism operates as a unified network, where the liver continuously recalibrates pathways in response to energy availability. Mastery of these interactions provides the foundation for our current and future interventions against metabolic disease.